This next presentation, we were very much looking forward to having this as a breakout session when we had originally planned our conference in Dallas, because one thing we always hear about DPC sometimes is it really scalable? Is it just a small time mom and pop operation, and how can it be scalable that in such a way that it would be beneficial to mediums and maybe even large companies with lots of employees? And so we have Dr. Kyle Rickner, partner at Primary Health Partners, to come today and share their success and how they've been able to scale Primary Health Partners around Oklahoma City and secure some really great contracts with the corporate business world and UCO, which we have the Director of Benefits from UCO here to help share that story. So, Dr. Rickner.
Well, it's so good to be with you. What a privilege. I mean, we're in the room with minds that think alike, but the stories of success and entrepreneurship continue to be inspiring to me. Dr. Dale, we appreciate what you've done, and our company uses you for all our employees, and so that's wonderful. And we appreciate that. So, I think what I'd like to do today is I'll just tell you a little bit about myself, and then how Primary Health Partners, or PHP, came to being, and try to tell you a little bit about our story and our journey, and maybe some of the barriers, and then some of the successes. We all have setbacks when we launch out, and mistakes and lessons learned, and we can talk about some of that. And then I'm very excited to sort of interview Justine today and let you hear things from the other side, which is always exciting for us. So I'm a family physician by trade. Did train here in Oklahoma City. And I've been fortunate enough to practice in multiple environments. My first one was predetermined for me when I signed a scholarship through medical school with the United States Army. And so when I finished my residency, my first job was already secured. So I practiced in a massive single payer system, if you will, for a little over 3 years. And so that was a interesting learning experience. I could stand up here for an hour and talk about that, because I reported for duty September 19th of 2001. So 8 days after 9/11. So the world changed, and it affected us deeply. So that was an interesting journey. But after 3 years and 2 deployments to the Middle East that were extended camping trips — this is why I don't camp today, had enough of that. So I actually stayed in North Carolina and joined a physician-owned group practice with 7 family practice doctors, 2 pediatricians, and 3 mid-levels. And they were very entrepreneurial. That was the beginning of sort of my business education, if you will, in medicine. And I learned a lot. I stayed there 2 years. And there were circumstances that came about, some in our personal lives with family health concerns, but we made our way back to Oklahoma. And in 2006, I signed my life away to a health system. I had tried to negotiate. I haven't told this story very much, but when I went into medicine, I was inspired by physicians that I got to work cleaning up their messes. So I was an orderly at a hospital. They don't use that word anymore, I don't think, but I took out trash and cleaned up blood in ORs and transported patients, and I got to meet all these doctors. 100% of them worked for themselves in the 80s when I was there. I was inspired by all of them, and that's actually what helped me make the decision to go to medical school. But then as time went on, and Keith eloquently sort of described the change of environment, the choices became limited and the number of doctors doing that went down. However, I still had hope. I was aware of a private group here that I could go in and start my own business. So I was actually able to start negotiations with some help from a hospital to get me started without being an employee. It was an ideal situation. And literally, I was in a tent in Iraq emailing with this administrator person when I found out they had just been bought. And so that went away. And so that's where basically the erosion of being independent went away. And I ended up inside of a health system for the next 9.5 years. There were a lot of changes in that time that I think are important to the story of every physician and the lack of entrepreneurship. They do tell you a story of, we just need you to be a good doctor and let us take care of all the details that you don't need to. And you know, what's happened over the last 15 years especially is we as physicians, shame on us, just reached in our pocket, took out the keys and handed them the keys to the kingdom and just said, tell me how you want me to do things. And so I saw a complete erosion of control. My choices became limited. I was dictated to. And during that time, my decision was, well, I want to help take back control. And so I'm going to get involved and I'm going to go behind the curtain. And I'm going to be a physician executive and I'm going to try to have a voice and I'm going to advocate for my other physicians. And it didn't work. There were powers that be that would let you say what you wanted to say and then decisions were made upstairs. And so I began to see this and was highly frustrated. The other thing that eroded entirely during that 10 years was the relationship context that was happening in the room with my patients. I began to realize the number of people that were actually in the room with me. It was the payer. It was my employer. It was the government. And I knew that because each of them were telling me to click different boxes on a screen to prove I was a good doctor and I was a good employee and I was a good American. And I became really aware of the fact that I was more concerned with getting the boxes checked. That was taking so much of my attention and so much of my time, frankly, that the patient was getting shorted. Now, I'm a pretty efficient guy in most arenas, so I was able to do it and do it well, but the patient was the loser. It certainly became a volume-based thing. The more I saw, the better I did. And so for me to actually give the patients what I needed, they either needed to wait a very long time for their appointment on that day or wait a very long time to get an appointment. I heard a comedian say one time that, he said, what is it with healthcare? When you need a doctor, it shouldn't be this hard, but I called the doctor's office and told them I'm hurt, I'm bleeding, I need to see the doctor. And they said, well, we'll get you in 2 weeks. And you're like, well, what's the problem? I'm bleeding now. And well, we can't get you in. Well, you find out the doctors you can get into really, really quickly, they're probably not very good. And so we have this thing about, oh, he must be really good. It's a 4-week wait to get in or a 6-week wait or whatever. And so that reality is not good. So access was terrible. So there was this little sliver of a regulation within the health system that still allowed doctors to basically employ a mid-level. And so I talked with my good friend, Dr. Robert Lockwood, and I said, hey, I think we can take advantage of this. And it scared him because it was change and it was a little bit of risk, but you know what? We did it. And it was working out well. So the time that they were taking away from me, I was getting some of it back. And in the process of making that decision, we kept track for 1 month, 4 weeks, and we found that 80 patients per week between the two of our practices were not getting in that called and were subsequently ending up in urgent cares or other places. And so the PA really helped that. Well, we just took full advantage of the system they had in place, and it became more lucrative than we thought to have this PA. But a lot of that was because he and I were out for meetings with the health system. And So I remember February 3rd of 2015, when we were sitting in a executive level meeting with the CFO at that time, and we were informed that there will be a change in that little niche that we found that is not consistent with a not-for-profit system. And so from that day forward, we would no longer make anything off the PA, and they retroed it back to the first of the year. I wasn't asked for my thoughts or choices, and I realized, oh my. The only thing that comforted me is that Dr. Lockwood and I had already been planning our escape. And plans were already laid. They didn't know it at the time. And so we both felt this squeeze, and we heard about direct primary care at a national meeting. We sat in a room like this, and after 1 hour, we went out on break just like we did, and we looked at each other and said, we're doing that. We don't care what it takes. The importance of that statement is not to be missed and has to be spoken by all of those that want to be entrepreneurs. It's mission. I don't care what it takes. We're going to do that. It was the right thing to do. I mean, the light bulb went off. And I agree with Dr. Dale. It's not that we need to make what we have better. We need to do something different. I heard it said one time that Edison did not make the light bulb as an improvement on the candle. It's completely different. So that's what we're about, is different. So that's what started our journey. DPC was very small at that time, and there were, we don't really know, but maybe less than 500 doctors doing it in the US at that time. So we tried to find out who they were, and I researched them to death, and I was all over everybody's websites, and we went and visited a few and wanted to create best practices for what our vision would be. And so we actually formulated 3 pillars that we wanted to build everything on. One was change the patient experience. It didn't matter how much my patients liked me. They hated the experience of coming to see me. And I purposely had patients that liked me that avoided coming to see me and would call me after hours because the process of coming to see me was so frustrating. So we wanted to completely change the patient experience, and this model definitely would allow us to do that. Number 2, every patient encounter basically was frustrating for the physician, because I knew all of the boxes I had to check, and I knew the other 2 people waiting in the room beside me. And if I hate being late, I hate people waiting on me, and I dealt with it every day. I had 2 words I said to every patient when I walked in the room. I'm sorry that you've had to wait or whatever, but I was tired of apologizing 30 times a day. So we wanted to change the physician experience. There were 80 primary care doctors in our group. And we were 2 of the 5 executive physicians that helped run that group. We were not aware of any of the physicians that were not utterly frustrated and unhappy. All of them were. They wouldn't complain. They made good money. That was really the only silver lining. Once that went away, there was nothing left. So we wanted to change the physician experience. And then the third thing is the realization we had, and I don't remember how we had this realization, was that 50% or more of all healthcare came through employers, businesses. And so their frustration with their health plans, one of my very, very good friends owned a quite large company at the time, and his frustrations with the health plan and for the employees, he had a little over 500 employees. I mean, he said, I don't even want to talk about it. The broker would show up once a year. Here's your plan. You're going to have a 17% increase. Okay, that's the best I could do. Okay. And he would sign on the line. And I mean, his costs were going like this. And so that frustration we were aware of, but we decided we wanted to be a part of changing that. So those were kind of the 3 pillars that we wanted to build on and get out from underneath this idea of doctors being so employee-based mindset, this lack of entrepreneurship, not only do we not have it due to a lack of training, it's actually we don't have it due to training. We have been trained to think like that. If you talk to any primary care doctors in the last 15 years, they don't really think about what exactly they're going to do as far as setting up a practice. It's just who they're going to sign with and who has the largest starting salary and sign-on bonus, whatever. And then they fill out their W-2 and do what they're told. And then they realize they're trapped and don't see a way out. And we're the nice guys in medicine. No offense to any specialists in the rooms, but we're the real nice guys. And we just say, thank you, may I have another? And we don't want to cause waves, and we don't want to be disruptive. But unfortunately, that's exactly what it has to take, is to be disruptive and have some courage and take some risk. We're also a very risk-averse group. So I think that the employees' mindset of physicians is one of our biggest problems. I go back to when I was an orderly, none of them were employees. And I remember talking with Dr. Moody, who was a general surgeon. I think he was 72 at the time and still operating, vigorous. And I can start to name many others. The retirement, they were doctors. It was a mission. It was a purpose. And now you talk to a primary care doctor that's 41 years old, and they will tell you when they're eligible for full retirement, when they can access their benefits. And it dawned on me that they've developed such an employee mindset that it's counterproductive to anything. And it just infuriated me with the realization that all the A students started working for the C students at some point. And it's like, what are we doing? And so I decided that we need to make a change, and we needed to provide a structure where physicians hopefully can branch out. And that was way, way more complicated than we thought. We knew that there would be power in numbers, but we didn't know how to get those numbers exactly. And so that's been an ongoing thing, and it's still a work in progress. And I'll tell you a little bit more about that. But, we realized that we were actually trying to fix a broken system. We wanted to be, I didn't want to continue to be part of the problem. I wanted to be part of the solution. And I realized that every transactional encounter with a patient did potential harm to that patient on the back end. We took an oath to do no harm, yet bills end up in their mailboxes because of decisions I made that harmed them. And I was so ignorant, I had no idea, because I was told, don't worry about that. You just be a good doctor. And that is just the immoral part of this, that I was used as a pawn to generate revenue, and that is all that I was seen as, was a very good revenue generating system. Just feed the machine. And they really didn't care about patients being patient-centered with what they did. They were revenue-centered. And when that realization really hit me, I became righteously angry. And that anger has fueled me to make change and to be disruptive. I don't mind making public comments that there are no health systems that I think need to be in my business, primary care. They're not doing it in the right way, and they're not doing it for the right reasons, and they're harming people in the process. Let us do that. We know how to do it. Get out of it. And we need you to be a hospital, because sometimes we need hospitals. I mean, people get sick. We need ICUs. They do serve a purpose. And there used to be a benevolence tied with that actually, we don't have time to get into the history of how hospitals really started and who ran them and how they operated. And we've bastardized the whole thing to the point of being ridiculous. But even in my young life, the idea that I remember the hospital at the time that I worked at had a relationship with the physicians and their practices to ask them, how can we help you with your patients? And now they say, I hope you're grateful that you get to see our patients. That's not right. Healthcare, as Dr. Dale said, is relationship-based, and it is the relationship between the provider, the physician of healthcare, and the recipient, the patient, not a system, not a medical record number. That there's no relationship there. So we wanted to fundamentally try to facilitate these changes. And so I saw direct primary care as the perfect way to do it. And it has grown a lot, but I want to be clear on what it is because there's some variations. Essentially, direct primary care is a model of primary care that the patient pays a monthly fee that is flat. They then have a relationship with a provider, that provider is available 24/7. And then there are no other professional fees or transactions that are done to the patient for harm. It is think of it like a medical gym membership. You don't pay your monthly fee to Gold's Gym and then actually have to pay extra to use the elliptical or treadmill. You just get in the door and can use whatever. So, it's very transparent, it's very clean, it's very simple. I tell people it is a way to bring some common sense back to the chaos that is medicine. It resonates with our elderly patients, which blew me away because it reminds them of how things used to be. We get to know our patients, we know their stories, and I don't need to have them come to my office to perform a transaction for revenue. I'm just available. So we take care of them in whatever way makes the most sense. We're available through multiple means. So this resonates with the heart of primary care doctors. We also are not paid by visits. So how many people I see in a day is irrelevant. It doesn't matter. And we limit our panels as the other key element that you have to call yourself that. And by doing that, that's how we can be available. That's how access is guaranteed, that you will see us same day, next day, that there's no problem getting in. That's very confusing to people because getting in is always a problem and access is a problem. And I'll touch on that a little bit because that's one of the criticisms of DPC on if you extrapolate it and you scale it. But I've got some ideas around that. So that's really where what DPC is. Now we have right at 1,500 practices in the U.S. that we know about. There's a lot of ones that we don't necessarily know about. And over the last 5 years, we have had so many doctors come and talk to us about doing DPC. And when they understand, I tell them all three things. If you're going to do this, you're going to have some transitional risk. It's going to happen. There's going to be some transitional sacrifice. No way around it. Doesn't matter how you do it. There's going to be some transitional sacrifice. And the third thing I promise you, fulfillment. You get to do it the right way. You get to do it in a way that you're patient-centered. It gets to the heart of why you went into this in the first place. Nobody graduating medical school and choosing family practice says, I want to be the best at generating RVUs. I got to figure that out. I mean, it's not where the heart is. I mean, like I said, we're kind of the nice guys and we sort of care about people and stuff. So it gives them a chance to really care about people and get to the heart of that. So that's really what makes it work. So, and in this organization, FMMA, and all of the change that we're talking about in the marketplace, I may be biased, but it all starts here. It starts with primary care. We're the entry point. it makes everything else downstream easier. It makes Jay Kempton's job easier if he has an advocate in the room with the patient that basically knows how to steer them. And it makes Keith's job easier because we just hand him over on a silver platter and we guide him to. So we become basically case managers on steroids for our patients. We become their ally in navigating the healthcare system. I tell every patient on their first visit, I make it my business to know your business. Do you have coverage? What is it? What's the deductible? We try to steer them in ways that will be best for the patient because I have no vested interest otherwise. None. And so that is actually how the family docs of old behaved. Every decision they made was patient-centered. And it wasn't RVU or revenue-centered. We have something that I would like to think would be consistent through DPC, but is not entirely, but it is at Primary Health Partners. There will never be anything that any provider can do to or for a patient in our office that will make them more money, period. The simplicity of that statement, far inferior to the implications of that statement from the patient perspective. Patients live suspiciously in healthcare. When they engage healthcare, they are so suspicious because they've been done wrong so many times. It's that what's going to hit you later? What's the real charge? I mean, I had to navigate a patient through an appendectomy this past week, and there was a part of the process I lost control over. And I know I'm educating my patients well because as she's home from the hospital for 30 minutes, she said, I'm wondering what that was going to cost. And I said, we'll figure it out. We'll help you on that backside if we need to. But we do not want physicians to be ill-motivated to do more to people to make revenue, where we look at patients as centers of revenue. What can I sell you? What can I do to you? What can I perform, et cetera, to enhance my own well-being and line my pockets? So that doesn't exist within our practice. And it's very refreshing for the patients. They realize that the elevation of the trust goes up at visit one like you wouldn't believe. They know I'm in their corner. And I tell them that monthly fee that you're paying, that's it. It's how I make a living. That's it. You know what it is. It's the same day every month that you pay it. And that's it. So if you're not okay with it, then that's it. That's fine. We lived through some angst this month because we had grandfathered in about 1,800 people to our clinics, but we had to make a price change a year and a half ago on new patients, and we didn't do it to the old ones. And we just realized economically it was time to just bump them up at $10 a month. We did so many calculations about how many people we were going to lose and And so it affected about 1,800 lives, and that went into effect, and we've lost 2. And what that tells me is we have value. People value us. We're still cheaper than most people's cell phone bills. And I don't apologize for that. I want to be affordable because what we do is not expensive. The analogy used with the oil change is perfect. We use that all the time, Dr. Dale. We're basically your maintenance guys. So we do the brakes, we do the tires, we do the oil change. This is not expensive stuff. You don't need insurance for this. And it starts to click and make sense with them. So it is very important to me that DPC, I think, is not only a different way to do primary care, it is the way to do primary care. And not everybody agrees with me when I say that, but I don't care. What I do is better. It's absolutely better. Everybody wins in my arena. It's a win-win-win. The staff love it better. The doctors love it better. The patients love it better. The outcomes are better, and we have data that proves it. So I think it's the way that it should be done. So I want to scale it. I want to grow it. I want it to take over. I get laughed at sometimes, but I would like to be able to stand up here at some point in the future and tell you we have more DPC doctors in Oklahoma City than we have employed primary care doctors by all the health systems put together. That's my crazy audacious goal because I think it's better. People win. businesses win, patients win, doctors win, staff wins. So I don't see a downside. And if you do, we can talk about it afterwards. So, but growing is challenging. You've heard about the barriers to getting doctors to transition over, and I could almost do a whole hour on that. Suffice it to say that we have to spend a lot of time talking with doctors through the steps about what this means and discussing that transitional risk and sacrifice. But I spend a lot of time on the fulfillment on the other side. It gets to the heart of who you are. And then the frontier that's going to change this, and it's going to happen, is when the residents are graduating and they choose us and not the health systems. It's going to happen because they're rotating with us now. They're spending time with us and they see this, and then it's like that other feels really icky. It's a big starting salary, but is that what's most important? And so we're planting seeds of doubt, and they're going to grow. They're going to grow, and that's going to happen. And so that's one way we grow the number of providers is it's a long game, and it's a long recruitment game, but we're going to work really, really hard at it. So we have to have the doctors to do the work, but we also need the work for the doctors. And so we refer to it in two different ways. We have what we call retail patients or off the street patients. This was the essential only area of growth initially, and it's the way initially that every DPC doctor thinks about their panel, is to get that individual person to go on their website and click sign up and do it. And that's great, because the more patients that do DPC, the more patients are going to do DPC. It's great, and I love it. That's oftentimes referred to when a single doctor does that and they have their panel as a micro practice where they are a silo of care. They're not really connected to anyone or anything. And there's a role for that. But if we want to be impactful and change and be the light bulb and not the candle, I don't know that that's going to get us there. And so the main conduit is through employers, self-funded employers, where we can make a difference on their plan and their pocketbooks. And so Robert and I, Dr. Lockwood and I, thought, yes, we're just going to do this, and we're going to go in and we're going to tell them the story, and we're going to explain this to them, and they're going to go, I agree, where do we sign? Boy, it didn't go quite like that. There's a lot of layers to this, and we realized our ignorance from being embedded in a health system. And so we have worked very hard and very diligently to get smarter people around us that know things more than we do, and then start to build relationships and realize that we're affecting a company and lives, and that's a huge decision, and we need a lot of players. And so I don't have time to talk through all of those steps that we've learned, but we're at a place now that I wish I could tell you about everything that's on the horizon with just us, because I'm giddy with excitement. But there's so much more to do. We have, just in the simple terms of business, the law of supply and demand. It is well published, the national shortage of primary care doctors. There's not enough of us. And because there's a plethora of urgent cares with whoever staffs it that day. And it's not superior to what we do. And so law of supply and demand says that we're going to win. There's more business than we can handle. But education and awareness is a big part of that. And so we grow a lot through word of mouth referrals. But with employers, we have to educate the employer. We have to interact with their health plan. We have to interact with whoever sells them that health plan. We have to interact with whoever administrates that health plan. And there is quite a process to that. So we have some big barriers. One legislative barrier that is a thorn in my flesh I was so hopeful when we opened January 1st of 2016 because there was already Senate Bill 1989. And that basically changed the definition of what you could use HSA money for. And it would include that direct primary care was an allowable expense. And it had bipartisan support. It still does. It's not passed, and there's been other versions that have been put through, but that one thing has not happened. So we have an employer partner in this city that everyone would know, and our participation with them is limited because they love that their employees can use an HSA. We love that their employees can use an HSA. It's a good vehicle. I like it. But if they have that as a major part of their health plan, they cannot have us. They can't. That's one of those regulation things that limit choices, take those choices away. So that's a big hurdle, even with self-funded employers, if they have that. I mean, to try to convince them to change fundamental parts that are good for their employees is difficult. So that's a big barrier for us. The other big barrier for us, as many of you in this room know, is how people get paid that sell health plans. And when we bring savings to a health plan, but we don't increase anybody's commission, we're not always in that conversation then. So old school brokers are not our friend. There's some really, really good ones, good guys, but the good guys are small in number, but they're growing. And so we've had to get down in those weeds and try to work there, which is very, very difficult as well. And there is definitely a move to change that. Healthcare Rosetta is a great program that does some education in that way, but it's going to be brokers doing right things in the right way for the right reasons. And I believe that with patience and integrity and time, we're going to see a fundamental change there too. When you're doing things wrong, it's going to catch up with you. I remember the very first employer meeting we had that was a gracious sort of, okay, fine, we'll listen because I know the owner of the company. But we were able to tell him what his broker's commission was the year before. And his eyes got as big as $50. And he said, well, he showed up and we signed the papers and I really only see him once a year. And I said, well, this is what you paid him last year. And he realized, wow, this is a broken system. But if I'm that broker, I'm pretty happy. So they're incentivized to maybe not do the right thing all the time. So here's what we've learned, that we have to build relationships directly with the employer and let them understand what we do and how it might benefit them. And some people, that's a really, really long game. And Justine Kendall, who I'm going to introduce you to here shortly, that was a short game. It was amazing. She got it quickly. It can be a really, really amazing, sometimes business saving solution. We have been fortunate to have a technology partner called KPI Ninja that can do cost and data analysis on, if we were part of a health plan, what would it mean to them? And it's really astonishing what the impact that we can actually have on the bottom line. And I love that. And I'm happy to do those analysis for anyone. But we've had people choose us as an option and said, we don't care if we save any money. We just want better primary care, better service, and better access for our employees. I was blown away by that. I'm like, well, this is probably going to cost you X amount of dollars more next year. That's okay. We don't care. All right. That's good. We'll move forward then. That's great. So how am I doing on time? Perfect. Justine Kendall, come up here. We were part of their health benefits. We were one of 5 plans in 2020. And there'll be some changes next year that I'll have her tell you about. So Justine, would you just start by telling us exactly what it is that you do and how did you become aware of DPC?
Yeah, thank you. So I'm the Director of Benefits at UCO. So in addition to medical, dental, life insurance, those type of things, we do employee wellness, leave, work-life balance. And so it's important for me when we design our benefit package to think about the holistic benefit that we offer to our employees. And so I'm always thinking of ways that we can add value to our health plan that is unique and competitive because, in case no one told you, higher education doesn't pay great. And so we try to add that value in different ways. And I had heard about direct primary care just kind of through network connections. But it was actually our current president, Patty Newhold Ravi Kumar, who barged into my office 2 years ago. And she had met with some physicians through PHP. And she had a pamphlet. And she said, "Do you know how cheap we can get amoxicillin for?" And I said, yeah, I'm aware we could do something like that. I've actually told you about that a couple years ago. And she said, "No, but have you seen the price of amoxicillin? I want to get more amoxicillin." I was like, okay, you go get all the amoxicillin you want. We can do something like this. And we met with, I call them the siblings Kale, two of the doctors through Primary Health Partners and their director of operations. And I just saw real value in what we could bring to our employees. And my hopes have been realized. And I'm just excited to continue to have this partnership grow.
Fantastic. Tell us a little bit, because we're early in the process, but tell us a little bit about what you've seen, what kind of value have you seen? What kind of feedback have you gotten? And then what has that led to in terms of your planning for next benefit season?
So when it comes to the population of employees and families that are in higher education, they're primarily older. They are less connected to their health care, but they're very connected to the richness and the value of their benefit plan. And so they want a really, really rich benefit that they may not use, but they're really adverse to change. And so that's a challenge for someone like me when healthcare is consistently evolving. And the biggest things that are our cost drivers for our population: hypertension, diabetes, things that are really preventable. And so I spend a lot of my time talking to our employees about, if you take these actionable steps, having a primary care doctor, getting your preventative treatment, things like that, you can drive the lower cost of our plan. But I'm just one voice. And so we needed a benefit that could tap into that. And I think Primary Health Partners does that for us, because for that low membership fee, we have somebody who is the advocate for our patient. And they're saying, okay, you have diabetes. I'm going to look at this holistically. I'm going to see how I can reduce your medication costs. I'm going to make sure that you come back in and you see me, and we make sure you're compliant with your blood sugar testing and your optometry visits and all the things that a normal primary care doctor may want to do but doesn't have time to do. So for me, the value is we have somebody looking out for our patients, our employees, in a way that can really impact our bottom line, and also is done with a tailor to empathy and compassion, which is important to me.
Love that. Tell us a little bit about the challenges to bringing that into a plan, and how maybe you're overcoming some of those challenges for next year, and if you're okay talking about what your goals would be enrollment-wise with DPC.
Yeah, so we offer a health savings account. It is something that is not really popular with our employee group because they're resistant to change. They are in that old school, really rich, low deductible benefit plan that every year goes up 10 to 15% in cost, and they're like, okay, great. And so we realized when we brought on direct primary care that we had to attach it to a benefit that was unique and was rich enough to kind of start to peel away the people that had been attached to their health plan for a long time. So we embedded it into a high deductible plan. It was not eligible for an HSA, but we matched it where the deductible and the out-of-pocket maximum are the same. So as soon as that patient hits their deductible, they've also hit their out-of-pocket maximum. And we kept that pretty low. It's $6,000 for an individual on our plan, which is less than the deductible on our HSA plan. We had a goal. I'm ambitious, and so I thought, I'm going to get, 25% of our patients or our employees to join this plan year one. I was wrong. We got about 100 people to join the plan, and I thought, well, what's missing? And so over the course of 2020, which has been our first year with PHP, I had lots of conversations with employees, and I said, help me understand what you want out of a plan and how we can design our plans better. And I consistently heard that mental health care was important to them. And that's not something that's currently offered through PHP, but the university has taken great effort in making mental health care affordable on all of our other plans. So for 2021, we're setting really low copays on our PHP plan for mental health care. So our employees can see a psychiatrist or an LPC for $25. So our goal in developing this plan with Primary Health Partners was if a member pays their premium outside of what they pay for maybe their weekly visits to a counselor, they don't pay anything else. They don't have those other costs where they're nickeling and diming and finding, well, I'm paying my premium, then I'm also paying an extra $150 or $300 a month on all the other things that are not coming out of my membership. So that's our strategy for 2021.
Yeah, and I'm not paying her. She shared, we had a little bit of discussion about some of these changes and a little bit of input because she asked me, how weird is that? I want to ask this doctor about what benefit changes might help get more people involved. I mean, I was actually blown away when we had that. So I had a number in the back of my head of how much we wanted to grow in terms of UCO, like how many more people. And then without her knowing that number, she shared she had a goal. And the two lined up like almost exactly. And so to have an employer partner like this is unprecedented. But I think what it highlights, at least from my perspective, is that the education gap is gone. She gets it. But then you had a unique opportunity to get it on another level, if you're okay sharing about your your family's personal encounter with DPC.
Yeah, so I am the resident healthcare guru in my family. My dad often will call me and say, hey, can you come over? You want to have a glass of wine? I'll make a steak and I'll show up and all of his friends have Medicare questions for me. And I'm like, this is not fair. You did not tell me what was happening. But my dad is an independent contractor, has been my entire life, and he's never had great health care. And I didn't realize he never had great health care until I got into health care. I didn't realize the struggles he was making when we were growing up to make sure that we got the care and the treatment that we needed. I'm one of 6 kids, and he's a single dad, so it was a struggle for him. But when I learned about direct primary care, I instantly thought of my dad. He has been on a high deductible plan through the Affordable Care Act that he pays an exorbitant amount of money for, and he never gets a benefit. He pays that because he knows he has to have health care, but then he's not eligible for the subsidies or the premium credits. And so after he pays his premium for him and my stepmom, which annual or monthly is about $2,000, he can't afford to go and get the primary health care that he needs. And so as he gets older, he just doesn't see a doctor. And I don't like that because I want him to be around for a very long time to see my kids grow up. And so I pushed him to look at direct primary care, and I connected him with a doctor at PHP who also happens to now be my doctor and my daughter's doctor. And the value that I see from that, I can just hear in his voice when he calls me and he's like, hey, I saw Mike today, and guess what? My cholesterol's good. And I'm like, that's great. And he goes, no, but that's really good because I didn't even know that I had to get my cholesterol checked. And I'm like, you're over 60, old man, come on. So it is important for me that he now has somebody that's not his nagging daughter looking out for his health care. And it's important for me that he has that advocate and that person who cares about him and checks in with him, because his health is not just important to him, it's important to me and the rest of my family.
Wow. Thanks for sharing that. That's great. So I think, being impactful and being massively transformational in our purpose has to connect at the personal level like this. And it's great to talk about numbers and how many lives and how many, that's great, but it boils down to where there's a face and a name and a story. And it's when you hear those and you realize those stories are changing, and that people may get to be around longer or live better, or at least the hand is held when things are going bad, that we're making a difference on a personal level as well. And the impact there is what stirs my heart. But the only way those impacts can be made is if we forge a way forward to grow this in a way that more people experience it and access it. And to Justine's comments, we have to be willing to do the work, to engage these self-funded plans. As doctors, we have to be more educated about what all of this is and how it works so that we can have intelligent conversations, because we're by and large pretty smart people, but we're pretty ignorant people when it comes to this. And so part of that is closing that gap. So I want to take the last few minutes, and I bet people have more questions maybe for Justine than me, but we're happy to field if there's any questions that came out of this today. Yes, ma'am.
I have a couple of questions. First is, yes, DPC, tremendous value. I saw it when I had my own DPC in Dallas. The thing that was missing was the education. With Hashimoto's, I really wanted more than just a referral to endocrinologists. I wanted maybe a little coaching to help me learn about gut health, to help me learn about stress management. So first question to you, do you foresee in the call of transformation, developing a workforce of coaches that work with the practice of the DPC to kind of clone you and help the patients be guided into that transformation? That would be, I'd love to hear your thoughts on that.
So,
new workforce. Yeah,
so two things on that. I get to do more than I have ever done for patients. I have grown in my own education about things I frankly didn't have time for because there were not RVUs tied to it previously. So my time, our physicians' time to talk about health, wellness, disease education, nutrition that aren't codable or reimbursable, so we didn't do it before, we do it now. And so the primary care physician actually begins to have more value in that role that you're talking about. The other thing that has developed is we have relationships now with some of those kinds of folks where, at least in our clinic in Yukon, we have brought in counselors. They're their own thing. They're a standalone thing. And we ask them, can you give us the best deal in town on counseling? And our patients will just pay you directly, and you can use my office space free of charge. It has increased compliance with counseling and access to counseling tremendously. And so now we're doing the same thing with some physical therapy. And one of the therapists happens to be big on nutrition and exercise and wellness. And so he's doing that. And it's not codable because they're just paying him, because we have a preset negotiated price. And so my goal over time is to bring under the roof of DPC more services that either are standalone that the patients pay, but I know they're getting the best deal possible. But there's also another way to do this to where there may be one global monthly fee that actually includes a lot of these other things. And there's a critical mass of numbers that has to happen with that. But we see that in the future, so that an employer, their price may be more than it is now, but it includes other medical services that are independent charges for them and ends up on their balance sheet that will be absorbed under our roof. And the implications of that can be huge. So I don't know if that answers your question.
It does. And my other question, it would be more like advice, because in Dallas we do have a Latino community health program with the DPC. We have the concierge that do the guidance into surgeries, and we have relationships with the labs, diagnostics, imaging, wholesale prices. And then we have the lifestyle education. So it's a Latino program. What's the best way to knock on the door of the employers like yourself and say, here we are, do you have a population? Would you like one that is tremendously sensitive to Latinos?
For me, I have to be able to affect the bottom line and also show that the value of what we're doing is worth the effort. And so the way that I kind of sold it up the chain, because it didn't need to be sold to me, I was like, yes, let's do this, is I took several dozen explanation of benefits from our big TPA vendor, and I took them to our vice president of HR and our president, and I said, do you know how much we pay, negotiated rate, for an office visit for a primary care doctor? And they were like, no. And I said, take a guess. And our VP of HR says, I don't know, $200? And our president says, no, it's cheaper, it's $100. And I said, okay, well, at least you guys are in the range. I feel better about that. It's $125. If we pay a membership fee for just one member to direct primary care at $70 a month, if that one patient goes in and has that membership, that is way less than cost of just one office visit. And so I tied it in a really tangible manner to them. And so for them, they were able to see, okay, it doesn't matter if we get 500 people into this plan, because the savings are there if we get one person into this plan.
Yeah, we're $90 a month, so probably could lower that. But anyway, it was for if you have a population that is Latino. I mean, I think that some employers would like to know that they are getting more sensitive care according to the culture and language.
Culture is really important for higher education, and so we also needed to find a partner that was based in empathy and relationship and compassion and advocacy. So it was important to me to find that provider that shared our values. And so maybe that's an angle that you can try to connect with an employer on, because I already have a broker and a third-party administrator that does the business side of it. I wanted the relationship side of it. So that was the competitive advantage that DPC brought for us.
If I could speak to that, we have found culturally there's different sensitivities to the engagement of healthcare. It's viewed differently in different cultures. And so we've seen acceptance in our environment by some and not by others. And so I would suggest that there are different employers and industries that either employ or have a lot of Latinos working there. I would go there, because as a whole, a lot of them here don't engage. the idea of being off work for any period of time to go get health care means they lose money. And they are so hardworking, they're going to keep their nose to the grind. And it wasn't until we had an employer partner that employed many Latinos and it was taken care of and they weren't going to be losing it. And they started coming to us that I started personally learning about this when I was seeing them. And most of them I had to have a translator there, a family member or something. So my eyes were kind of opened that they don't often have any thought about, they're very, or at least the information I got was that they were very focused on episodic, transactional, quick care. So those employers would say, go to that urgent care, get that fixed and get back here. So the idea of health and wellness is, so I think your engagement, but healthy employees have a higher degree of presenteeism and less absenteeism. And so that would resonate with that employer that if you want them to stay healthy and stay at work, you have to prevent some of these things that run higher in the Latino population. And that's where we can help you. So that would be my input. Any other questions at all? Good. I appreciate the time. I hope it was helpful. Thank you very much. Thank you, Justine.